Welcome back, everyone. Today, we're going to shift our focus to a perspective that often gets overlooked in technical training: the culture of healthcare and how it directly shapes your work as biomedical equipment technicians and clinical engineers. Because here's the thing, you're not just working on machines, you're working inside a living system, a system made up of people, processes, and values. And every time you calibrate a device, manage the life cycle of technology, or you troubleshoot equipment under pressure, you're part of that bigger fabric. And that's where systems thinking comes in. This framework isn't just about understanding how things work, it's about understanding why they sometimes don't work, why, despite good intentions and solid engineering, failures still happen. Systems thinking helps you to see those connections, it helps you to spot the hidden weak points and understand the culture and context that surround the technology. So today's session is about expanding your view, not just the technical, but the human and organizational side of healthcare, because to truly succeed in this field, you're going to need both. Now, as we move into the second part of this series, I want to point out that the same learning objectives from the first part still apply, but this time we're viewing them through a different lens, which is your lens as a biomedical equipment technician and as a clinical engineer, and in some cases, biomedical engineers from academia. So, what does that mean in practice? So, when we talk about understanding health and healthcare, we're not just talking about medical definitions. We're talking about how health is shaped by social and cultural forces and how those forces influence which technologies get prioritized, funded, and adopted in different settings. When we revisit what culture is, we'll broaden the view. It's not only about ethnicity or tradition, it's about how healthcare teams operate, how values are communicated, and even how unspoken norms like where equipment gets placed or how staff respond in emergencies can shape outcomes. Cultural competence for you as engineers or in the engineering related fields, it's not about treating patients directly, and it's about collaborating with diverse teams, using that patient centered language and making sure systems you design or that you maintain reflect the messy realities of clinical use, not just the technical idealism. And when we compare culture, safety, and healthcare, we'll be looking at concepts like safety culture and blame culture, and how engineering choices directly influence risk perception, reporting, and system resilience. And yes, different cultures affect healthcare even within a single hospital. So every unit, the ER, ICU, OR, has its own little microculture, and success in your role often depends on how quickly and respectfully you can adapt to these overlapping environments. And that ties into what we mentioned before in the previous lecture, acculturation. And so learning to speak the language of healthcare teams, navigating authority structures, and picking up on unspoken expectations. And finally, in this session, we'll talk about the culture of technology, uh, where technologies are not neutral, right? Where they reflect the assumptions and biases of the people who designed them. And your role is to recognize those biases and help bridge the gap between technical tools and human systems. So by the end of the session, you should have a stronger grasp on how your work is more than just technical. It's embedded in a complex human environment, one of the most complex human environments, I would add, and a culture, and it's all glued together by the systems that hold them together. Let's start by connecting today's session to where we left off. So, in our last lecture, we unpacked what culture means in a healthcare setting. We saw that it's not just about nationality or background, it's also about how professionals communicate, how decisions are made, and even how time and urgency are understood in clinical environments. Today, we're going a step further. We're asking, why does it matter for you as a biomedical equipment technician or as a clinical engineer? So think about it. The tools and systems that you design, maintain, or troubleshoot are used by people who are shaped by these cultures. If your technologies are going to fit seamlessly into clinical workflows, you need to understand the human systems that they operate within. And so here's what we're going to explore: how culture or how cultural factors influence technology use and acceptance, why communication gaps between engineers and clinicians often come from unspoken cultural norms, and how you can start observing, questioning, and designing with cultural insight. This isn't just about soft skills, this is systems thinking in action. And it's the difference between technology that simply works and technology that truly supports. So let's go ahead and get started. Before we dive deeper, let's ground ourselves in the basics. So, what do we actually mean when we say culture, and more specifically, healthcare culture? So, in general, culture includes the shared behaviors, values, language, customs, and beliefs that groups pass on, sometimes without even realizing it. And this doesn't just apply to ethnic or social groups. Professional groups have cultures too. Engineering has a culture, nursing has a culture, medicine, respiratory therapy, pharmacy, they all do. Now let's zoom in on healthcare culture, right? So this is the collective mindset, the communication styles, and the institutional norms shared by clinicians, nurses, managers, and allied health professionals. These shape everything: who speaks first in a team meeting, how errors are reported, even how quickly decisions are made in a crisis. For engineers, understanding these unwritten rules is critical. It allows you to collaborate more effectively, navigate interprofessional tensions, and most importantly, design or manage systems that actually fit into the messy, real world context of clinical care. And the key point here is that much of this culture is never formally taught. You don't find it in a manual. You learn it by watching, by listening, by being present in the hospital environment. That's why engineers who spend time on the floor, shadowing clinicians, observing workflows, often become far more effective problem solvers than those who rely purely on technical specifications. So as we move forward, keep this in mind. You're not just designing for a healthcare system, you're designing within a healthcare culture. Here's one of the most important concepts for engineers in healthcare: there is never just one culture at play. So when you think about it, whether you're observing a code blue, installing a device, or analyzing a failure report, you're not just watching a single system in action, you're watching multiple overlapping cultures interacting at once. A nurse may be working within the culture of bedside care, focused on safety protocols and patient advocacy. A physician might bring a very different lens, centered purely on diagnosis, authority, and time efficiency. And you, as the biomedical equipment technician or as a clinical engineer, are shaped by your own culture, one rooted in logic, precision, troubleshooting, and systems thinking. And here's why it matters: no single perspective explains everything. If a new device isn't being used correctly, it might not be a design flaw or a simple user error. The problem could actually be cultural. Maybe it's about how time is perceived. Maybe it's about how risk is managed, or maybe it's about how team members communicate under pressure. To be effective, engineers need to recognize two things. First, the plurality of cultures involved in every clinical encounter. And second, that our own understanding is always partial. We don't see the whole story unless we zoom out, ask questions, and look beneath the surface. That mindset, seeing culture as layered and complex, will help you design better. It'll help you collaborate better and troubleshoot with empathy as well as insight. Now, let's shift gears and talk about ethnography, a tool that can completely change the way engineers understand the culture of healthcare. So, traditionally, ethnography is the method anthropologists use to study life in a community. It means immersing yourself in a setting, learning the language, observing daily life, and documenting how people interact, solve problems, and make decisions, all from their point of view. Now, here's a twist. As clinical engineers or biomedical equipment technicians, you don't need a passport to do this. Your foreign country might be the surgical suite, a patient's room, or the nurse's station. The language isn't Spanish or French, it's clinical shorthand, acronyms, and the unwritten workflow rules that only those insiders know. So, your goal is to see healthcare from their perspective, not yours. To understand how doctors, nurses, and techs think and how they communicate and how they use technology in real time. So, why does this matter? Well, because technology integration doesn't succeed on technical specs alone. It succeeds when the equipment fits into daily routines, values, and unspoken rules of the people who actually use it. So think of yourself as an ethnographer of the hospital floor. Listen closely, observe patterns and breakdowns, ask yourself why certain behaviors make sense to them, even if they look inefficient to you. And that shift from imposing your technical perspective to learning theirs will make you not just a better designer and troubleshooter, but also a stronger teammate in the healthcare system. As clinical engineers, you live in the space where technical systems meet human behavior. And one of the best ways to notice cultural differences in that space is by spotting what anthropologist Michael Agar calls rich points, right? Rich points are those moments when something feels off, confusing, awkward, or not what you expected. They're clues that different cultural assumptions are at play. Take language, for example. A physician says patient, a therapist says client, a billing clerk says customer, IT staff say users, and you might think in terms of device operators. Each label reveals different assumptions about roles, relationships, and expectations. Even a clinical term like chief complaint sounds routine to doctors but judgmental outside of medicine. Here's another case. A physician working in an IT office picks up any phone to return a call, but they interrupt conversations to answering pages, which is like the normal flow of workflow there. Now, the physician picking up the phone may be normal in a hospital unit where urgency is rules, where it's most important. But in the IT office, desk phones are personal property, or they're seen as personal property. And so interrupting uh, by grabbing someone's phone is considered rude. Same behavior, different culture, and this is where we get a clash. We see this in technology too. So outpatient offices often use fixed personalized workstations, but in a hospital, clinicians need fast, flexible access anywhere. So if a new system is designed with office assumptions, it won't fit hospital workflows. And then you're going to get frustration and a lot of workarounds are going to start developing and following. So for you, when you think about a rich points are diagnostic clues. They reveal where technology meets resistance, why workarounds appear, and how communication breaks down. So we need to learn how to spot them, and you're going to learn how to design and troubleshoot systems that truly work in the cultural reality of healthcare. As clinical engineers, you're often the bridge between two very different cultures, clinical practice on one side and technical operations on the other. And one of the most valuable tools you'll have in that role is the ability to spot and interpret what we call rich points. Rich points are those moments, again, when something doesn't make sense. Maybe a clinician acts in a way that feels inefficient, resistant, or puzzling from your engineering perspective. Instead of dismissing it, you pause and you ask, what cultural assumption am I missing here? These moments are gold. They reveal workflow gaps, mismatched priorities like speed versus precision, or even conflicting values, such as whether equipment is seen as a shared resource or as personal property. Your job isn't to correct the behavior, it's to translate, to bridge the meaning between professional cultures. That translation is never perfect because culture is fluid and context always matters. But even a partial translation improves communication. It improves trust and it helps systems integrate more smoothly. So think of it this way: anthropologists translate between global traditions like traditional healing and Western medicine, right? You translate between clinical culture and engineering or IT culture. So every time you walk onto a unit or answer a request, remember you're not just fixing machines, you're connecting across cultural systems, and the more rich points you chase, the more fluent you become in both worlds. Let's be honest, most of you didn't go into clinical engineering because you wanted to study culture. You probably came in drawn to systems, hardware, compliance, performance metrics, but here's the reality: to succeed in healthcare, you have to understand the human system too, and that's where cultural competence comes in. Now, just like medical students, engineers run into some common challenges when asked to think critically about culture. And let's walk through a few of those. First is resistance. You might hear or even think things like, I didn't go to engineering to deal with this stuff, and or I've got more important technical issues to worry about. That's natural. But here's the catch. Most technical failures in healthcare don't actually come from broken hardware. Technicians will tell you this right off the bat, right? They can confirm this. They come from breakdowns in communication, trust, and or workflow mismatches, and these are all cultural issues. Second, ethnocentrism or denial of biases, right? Engineers love objectivity. We lean on data, but even data driven thinking carries assumptions. How we define efficiency, error, or ownership isn't universal, it's cultural. We don't recognize our own filters. We miss how others interpret the use of technology differently. And third, stereotyping and oversimplifying. It's easy to slip into this type of thinking. Nurses are like this, or IT staff always do that. But culture is uniform, right? It isn't uniform, excuse me. Um, Different shifts throughout the hospital, different departments, even different generations within the same profession can have completely different norms. Um, and the other thing, the othering, right? This is pretty important. This happens when engineers view clinicians or clinicians view engineers as the other group, right? Things like they just don't understand technology or engineers don't care about patients. That mindset creates silos, right? Even when everyone is trying to solve the same problem, right? But we're all trying to solve the same problem, but just through different lenses. So the bottom line is this: cultural competence isn't about being nice or politically correct. It's a core professional skill. It's what allows you to design, communicate, and implement technology that actually works in the messy human reality of healthcare. Cultural competence isn't just a challenge for doctors, nurses, or medical students. It's just as relevant in health technology, informatics, and clinical engineering. And the same barriers we talked about earlier still apply here. So again, first is resistance. And again, we've heard of this, right? You think I didn't go to engineering or informatics to learn about culture. We've got uptime to maintain. This feels like fluff. But here's the reality. Most breakdowns in health IT or biomedical tech aren't technical, they're relational. They come from cultural gaps, misunderstandings, miscommunications, or failing to align tools with clinical workflows. Second, we said ethnocentrism or the denial of bias. Technologists often assume they're neutral or objective, but every system reflects the assumptions of its creators. A user interface designed for a quiet office might frustrate staff in a noisy ER. An access control protocol may look perfect in theory, but block critical handoffs during a busy shift. So, unless we recognize our own cultural defaults, we can't design effectively for others. Again, we mentioned stereotyping and oversimplifying. It's easy to label clinicians as resistant to change or bad with tech, but healthcare culture is diverse, complex, and it's adaptive. When engineers oversimplify, they miss safety cues, misjudge feedback, and end up building systems that don't last. So remember that culture isn't monolithic, it's plural and constantly evolving. And finally, the othering that we mentioned. Again, this shows up when we start thinking in terms of us versus them. Engineers on one side, clinicians on the other. And that mindset leads to blame when systems fail, frustration during rollout, and poor collaboration. Remember, the term is clinical engineering for a reason. So, right? So we should be exemplifying both, right? But going back to go to the other, so even the word user can unintentionally reduce clinicians or patients, right, to a technical role that ignores their urgency, expertise, or context. And so here's the takeaway: these aren't abstract issues. They show up in your work every single day, from system design to troubleshooting to workflow optimization, right? Cultural competence isn't extra, it's essential to doing your job well in a clinical setting. I do want to throw one more thing here is that there are a lot of parallels to the clinical environment and the education environment and some of the issues I'm seeing in one organization I am seeing repeat in the other organization, and they both have the cultural root underlying both of them, which is very, very interesting. So let's say you're on board, you understand that culture matters for the success of any system you design or you implement or support. And the real question becomes, where do you look to understand healthcare culture so you can work more effectively within it? You start with people. Watch how everyone behaves, not just doctors or nurses, but housekeeping, transport, clerks, patients, even the families. Notice their attitudes toward urgency, risk, and ownership of space or the tools around you. Then consider the places. A tertiary hospital or a rural clinic and a patient's home each come with different norms and technology demands. The context shapes culture and how your equipment is used at the same time. Then we can look at processes and practices, observe routines, informal workarounds and timing. Why do people bypass alarms? Why is that pump left unplugged? These answers live in daily culture, not manuals. So don't forget values and beliefs as well. Sometimes official policy says report all safety issues, but the real culture penalizes speaking up. So listen for how values surface in stories, jokes, or language under stress. Of course, there's interaction with technology. This is your wheelhouse, excuse me. But approach it with fresh eyes. How do people actually use a device? Do they avoid some? Do they repurpose others? There's a person named Ed Hutchins, and he said, "We cannot know what the task is until we know what the tools are." And I add, we don't really know the tool until we see how it's used. So finally, watch out for cultural signals. Symbols like white coats or badge tiers, medical jargon, abbreviations, heuristics like treat the patient, not the lab, and even folklore. Who gets called the hero problem solver on the floor? The more observant you are, the more culturally literate you become. And that makes you not just a technician, but a systems thinker embedded in healthcare transformation. As clinical engineers, you work at the crossroads of multiple cultures, the technical, clinical, regulatory, and sometimes even patient facing. And here's the challenge: your own assumptions about those cultures can sometimes work against you. So, first, avoid the myth of fixed professional cultures. Anthropology has moved past the idea that any group has a single, unchanging way of thinking. The same applies here. There isn't one clinical culture, one engineering mindset, or one nursing perspective. Instead, you're navigating a mesh of overlapping, evolving microcultures. If you assume there's just one way a group behaves, you risk misreading situations or missing valuable input. Second, why does this matter to you? Let's say you're troubleshooting a reoccurring issue with an infusion pump. If you jump into the conclusion that staff are simply resistant to training, you might miss the real issue, a conflicting protocol maybe, or a layout that disrupts workflow, or even a workaround that makes perfect sense in context. So stereotyping shuts down your ability to see clearly. Third, translate, don't reduce. So instead of squeezing people into neat categories, learn to translate across systems and values. So, for example, what looks like a data entry failure might actually be a nurse's way of prioritizing patient care because in their culture, immediacy matters more than documentation. And finally, focus on the issues, not identities. That shift keeps your attention on workflow conflicts, data mismatches, or equipment constraints rather than stereotypes about professions or the users. The takeaway is simple: cultural awareness isn't about labeling groups, it's about recognizing complexity, avoiding oversimplification, and staying open to perspectives that might surprise you. To wrap up this section, let's look at how field studies, especially ethnographic ones, have shaped the design and evaluation of health technologies. The lesson here: technical design only works when it's grounded in real world use. For example, early workstation studies by Champs and Forsyth showed how physicians and nurses actually use their setups. Redesigning based on observation reduced cognitive friction and supported better decisions. In critical settings, Forsyth, Hull, and Paul found that formal system logic didn't match how ICU teams made sense of chaos. The insight: design has to support teamwork, not just individuals. Emily Patterson's work on barcode medication systems showed how tech can create side effects like alert fatigue or risky workarounds. Nancy Vukovic revealed the power of what was informal communication, those hallway chats and nurse glances that drive care, but never show up in a record. Right? Systems that ignore this invisible layer often fail. Marie Catherine Bucart Zephyr uncovered how computerized order entry increased cognitive load and strained doctor nurse cooperation. And there are also studies from Bill Ventures, who was a video ethnographer, and he showed how even computer placement in exam rooms can shift eye contact, um, you know, shift attention and trust between doctors and patients. The bottom line is field studies don't just give anecdotes, they give evidence of how tools are really used. If you want systems that stick, get adopted, and improve outcomes, these are the kinds of insights you need to learn from or conduct yourself. As we wrap up on the culture of healthcare technology, let's pull the key takeaways together, especially for your role as either biomedical equipment technologists or clinical engineers. First, remember, technology alone isn't enough. A device only works if it fits the people, places, and processes around them. That means paying attention to workflows, team dynamics, communication styles, and values, not just the specs in the manual. Second, culture is not one size fits all. There's no single clinical culture. Culture is plural, partial, and relational. It shifts depending on who's interacting and where. Your success depends on recognizing and adapting to that complexity. Third, watch for those rich points, right? Those moments when things don't go as expected, when a device is ignored, a feature is misused, or a request seems unclear. These aren't just problems, they're signals of deeper cultural disconnects and opportunities for redesign, or retraining, or rethinking. Fourth, practice cultural competence. Avoid assumptions, stereotypes, and the othering, right? Saying the nurses just don't get it or the IT team always complicates things. That only blocks collaboration. Competence here means staying curious and solution focused. And finally, use these insights to improve technology. The best engineers don't just fix machines, they understand the human systems those machines live in. That's what leads to smarter deployments, safer performance, and real impact. Let's pull the big lessons together and look at what they mean for your future work in biomedical equipment technology and in clinical engineering. First was culture. We started with this classic anthropological roots, shared language, beliefs, and customs, and extended that into modern systems thinking, how professionals operate with an environment shaped by roles, tools, and training. The key insight: culture isn't fixed, it's active, adaptive, and always shifting. Second, remember that culture is partial, plural, and relative. You're never working with just one culture. Every hospital department, every profession, even every shift has its own microculture. And your view of a situation is always partial. It's shaped by your own background and assumptions. Third, concepts like cultural competence, safety culture, and just culture, they matter directly to your role. Cultural competence helps you collaborate across disciplines. Safety culture ensures systems protect, not alienate. And just culture supports openness and learning from error. It's critical in tech heavy environments where mistakes are usually inevitable. Right. Fourth, we emphasize the importance of multiple cultures and contexts. So your work, whether it's configuring devices, managing alarms, or briefing a clinical team, it always happens in a shared cultural space. So your success comes from recognizing and translating across those overlapping worlds. Fifth, keep an eye out for rich points. Those moments when things don't go as expected. They're clues to deeper cultural dynamics. And through acculturation, you'll learn how to adapt, how engineers pick up clinical language, and how clinicians adapt to new technology. And finally, we saw how health informatics and field studies let us analyze culture systematically. Right? These aren't abstract theories, they're practical tools for designing better systems and safer workflows. So here's the final thought. Understanding healthcare culture isn't just about empathy, it's about engineering systems that are resilient, safe, and truly usable. You now have a cultural lens to bring into your technical work, and that's a powerful step forward in your future as an engineer, designer, and analyzer.